Dr. Wissam. So our next lecture will be sonographic approach of respiratory failure. This is a very important hot topic in our practice now, and it will be presented by Dr. Sudipta. He is a consultant of critical care medicine in Tata Medical Center in Kolkata, India. Dr. Sudipta, you have the mic. You can proceed, please.
Hello. Hello. Good evening, everybody. Am I audible?
Good evening, sir. Yes, you are audible. Proceed, please.
So my topic for next 25 to 30 minutes will be sonographic approach of respiratory failure. And we'll proceed through a case, but what we'll do in between, we try to cover the basics of lung ultrasound, the evaluation of different abnormal clinical finding, how to evaluate the airway related to a shortness of breath, how to differentiate between cardiac and non-cardiac cause of dyspnea, and some sonographic evaluation for weaning failure. So we'll start with a case, a 60-year-old lady, diabetes, hypertensive, acute lymphoblastic leukemia, received chemotherapy recently and now admitted in the ward with shortness of breath. She was initially managed with supplemental oxygen and antibiotics. With worsening in the hypoxia, she was shifted to ICU. And eventually she was intubated and ventilated. And FIO2 requirement was nearly 80%. Chest X-ray showed bilateral haziness. Now, with this high oxygen concentration, we could not do the CT scan. Now what? What further investigation we can do? Can USG lung help in this situation? So whenever we are doing lung ultrasound, we use linear and curvilinear probe. The linear probe is used for the surface assessment, that is the skin, subcutaneous tissue, pleura, and the immediate subpleural area. These are high frequency probe. These are better resolution, but poor penetration. So good for surface assessment. Curvilinear probe, which has a lower frequency but better penetration, usually used for the deeper structure. That means base of the lung, diaphragm, and subdiaphragmatic space. Now we all know that lung ultrasound is basically interpretation of the artifact, and by convention we know that ultrasound beams cannot pass through the air. So there are some basic preset changes may be needed in lung ultrasound, because in conventionally there is a setting for routine suppression of the artifact, which will not be applicable in ideal situation for lung ultrasound. So we need a dedicated lung software, that is the lung preset. We have to turn off compound imaging and harmonic imaging, and we have to reduce the dynamic range for better picturization. Whenever we are doing lung ultrasound, for the purpose of description, we divide that area into 6 zones. As you can see in the picture, the vertical lines are the lateral margin of the sternum, anterior axillary line, and the posterior axillary line. And the horizontal line is passing through the nipple or fourth intercostal space. So the zone that are developed is zone 1, zone 2, zone 3, zone 4, and zone 5 and zone 6. And so whenever we are doing a lung ultrasound, we have to evaluate all these 12 zones with our probe. And while setting the depth, specifically for the assessment of the base, ideally it should be 9 to 11 centimeter anteriorly and 15 centimeter at the base in the mid or posterior part. Because if the depth is too much, we cannot see the pleura like in our picture. And whenever we are putting the probe needs to be perpendicular to the pleura for better delineation. If it is out of the plane, we may get a pattern like in my picture, which is called a non-A, non-B pattern, and we cannot evaluate anything. So these are the small points we need to keep in our mind. Another very important concept is that whenever we are doing a lung ultrasound, it is basically evaluation of the tip of the iceberg. Because if there's a underlying lung pathology, we can identify it if it has some pleural representation. If it does not have any pleural representation, we will not be able to evaluate it. So while starting our scan, we'll start with the cephalocaudal direction. We put the probe vertically or in the longitudinal direction, evaluate all the 12 zones. If we get a pathology, then we'll turn on the probe into that area and we'll evaluate in the transverse zone. Now, lung is very unique in terms of ultrasound assessment, because it has some true area or true image that constitutes by skin, subcutaneous tissue, and the ribs and the muscles, and the pleura. Below pleura, these are all artifacts because of the reverberation of ultrasound from the surface. So the up part is true image and up part is artificial or false image or artifact. Whenever we are describing lung ultrasound, this is the classical image, which is called batwing appearance. It forms by the two ribs and the black shadow below it, and the sharp white line, hyperlucent line, that is the pleura. And below the pleura, there will be multiple horizontal lines, which are called A lines, which are the normal lung finding. So what are the criteria of A lines? It is produced by reverberation artifacts. There are horizontal lines parallel to the pleura, and it is separated by regular intervals, which are equal to the distance between the skin and the pleural line. It is seen in normal and aerated lung. That means that this is the distance from the skin up to the pleura. The distance between each A lines will be equal to this distance. Once we find the A lines, we have to go look for the lung sliding. It is, we can see, it is a to and fro movement between the parietal and the visceral pleura in each breath. It indicates the underlying lung is moving. While doing lung ultrasound, we need to remember that all the findings in the lung ultrasound will give us pathophysiological information. It is not going to make any definitive diagnosis for us. And accordingly, we have to get our clinical diagnosis. So if we wanted to confirm this movement, we have to put a M mode through it. And once we put the M mode, we'll get a picture like this. The upper part, that is the skin and the subcutaneous tissue, are not moving. This will give horizontal barcode-like pictures. And the below the lung part, because it is moving, it will give a granular picture. This is called seesaw sign. This is the normal lung finding. But what happened in our case, when you do this assessment, we found a picture like this. So what we can see hyperechoic, well-defined laser-like lines, which are described as comet-shaped, which is starting from the pleura and it is moving with respiration on the pleural line, and it has obliterated the A lines. So all these points are important. Whenever we get B lines like that in the lung, we have to differentiate that whether it is cardiac origin or non-cardiac origin. So for cardiac origin, it has to be homogeneous because the pathology is outside the lung, so it should be equally distributed into the both lung. There should be gravitational distribution. That means the upper part will have less B lines compared to the dependent part. Because the underlying lung is normal, so we should have a smooth pleural line like in this case, and there should not be subpleural consolidation. See, here we can appreciate this is the pleural line, and there is small hypoechoic lesions below which the B lines have started. These subpleural consolidation. Here, this is because of ARDS, there are multiple subpleural consolidation. It indicates there is an underlying lung pathology in the production of B lines. Now, next, what happened in our patient on the day 2? There is a new onset sudden desaturation, apparent worsening in the clinical function. If I have to increase this to 100%, what can be the cause? And can ultrasound help? We know whenever there is an acute desaturation, we start our evaluation from both airway. We ensure that tube is in place and then see what is the new onset lung pathology in our patient. So can we confirm the tube position with an ultrasound? Now here we can see this is the trachea, and you can see with the minimum movement of a tube, we can appreciate an undulation here. We cannot see the endotracheal tube clearly because the cuff will be inflated by air. So there will be artifacts, but we can clearly identify that there is an abnormal movement. There is undulation happening here. So that means the ET tube is in the trachea. Now, if it is not in the trachea, we'll get a picture like this. Ideally, tube should be here. Here, if it is the esophageal intubation, then the tube will be just lateral and behind the trachea in the esophagus. It happens sometimes the tube comes out, nursing staff on that moment just pushed it inside, and by accident it goes to the esophagus. It can happen and do happen sometimes. Now here we can clearly appreciate the nasogastric tube in the esophagus, which is lateral to the trachea. Now if the tube is here, we'll get similar picture, a railroad sign or double line sign. Another thing can happen, it can be an endobronchial intubation, and most commonly it happened to the right chest because the right bronchus is straight. What we'll get in the right side? Right side will get a normal ultrasound finding. the lung sliding is there and A pattern is there. What will happen to the left side when the lung is not getting ventilated? There is also a movement happening in the pleura, but the rate is much, much higher. It is not equal to the respiratory rate, if you can appreciate, right? These are called, and there's no pleural sliding, which should happen with the each beat. So there is pleural sign absent, and this is called lung pulse. This happens because of transmitted cardiac pulsation to the pleura, because the underlying lung is not moving. And the baseline underlying lung, because it has air, there will be A pattern. So by this, we can diagnose an endobronchial intubation also. We may get our patients like this, and we will suspect a subcutaneous emphysema. It can happen in a intubated patients. So if there is not in our patient, but if there is a tracheal injury, we'll get vertical lines, not from the pleura, but from the subcutaneous tissue, like this. And this indicates that there is air in the tissue, and we cannot evaluate the deeper structure because of the artifact. So we can diagnose subcutaneous emphysema also. Now, what happened in our patient when you do the lung ultrasound? We found there is a confluent B lines that we can see. If you look at the lung ultrasound finding from left to the right, you can clearly appreciate there is an increase in the density of the B lines. It indicates there is a worsening in the pulmonary edema. If there is an increase in the number of B lines, it indicates that more dehydration has happened. So lung ultrasound can be used as a monitoring tool also. But some drawbacks also we need to remember, as we have learned that B profile with a regular pleural line, it indicates a cardiogenic pulmonary edema. B lines with irregular pleural line indicates ARDS or subpleural consolidation and underlying lung pathology. But what happens if we get a profile with an irregular pleural line? We do not know the clinical significance in critical care. What another thing it can happen in this patient, it can be pneumothorax. So what will happen in pneumothorax? Because there is air between the parietal pleura and the visceral pleura. So underlying lung, true lung is not there, but there is free air. So what will happen? There will be lung sliding will be absent. And once you put a M mode, it will show stratosphere sign. I will show that. Lung pulse will be absent because as there is air, cardiac pulsation cannot reach up to the pleura. B lines will be absent because this is the air and no fluid can be there. A line may be present, and in extreme cases, if you are lucky, we can get lung point. So what is lung point? Lung point is the transitional point between the mobile and the immobile lung. This is the point where the parietal and visceral pleura has got separated. And this is very classical or pathognomonic of pneumothorax. Once we put a M mode here, we will found there are horizontal lines in the lung, just like the tissue, because the lung is not moving. This is called barcode sign. But there are some challenges also. In certain cases, we can get a false positive result if the underlying lungs is poorly ventilated. That can happen in a COPD emphysema patient, lung bulla, patient with apnea, post-pleurodesis, very high P for endobronchial intubation, or a morbidly obese patient. There the lung sliding may be little unsatisfactory or difficult to pick up. And sometimes if accidentally the new fellow is putting the probe on the rib, you also may get a false absence of lung sliding. On the other hand, what are the cases of false negative? That may happen because of a trapped pneumothorax. The ultrasound may not be tracking the proper pathway of the lung and fail to pick up the lung pulse. And so, also with an ultrasound, we cannot diagnose the severity and the extent of pneumothorax. So we need to remember the sensitivity of the ultrasound for picking up pneumothorax is not that great. It is around 70%, as good as chest X-ray. So if the patient is clinically deteriorating, we should consider for a CT chest. E lines we already have discussed in case of subcutaneous emphysema. This generates when there is a free air within the tissue. These are vertical laser-like lines, just like B lines. It will start from the tissue, not from the pleura, and may reach up to the skin or may end below at a certain level. And there is another vertical lines which is called Z line. So we need to remember all B lines or vertical lines are not B lines or indicating pulmonary edema. See, here we can see this is the classical B line, with the B line starting from the pleura and coming up to the base of the screen, and it has obliterated the A lines. Here, there are vertical lines which are not all are coming to the baseline, to the base of the screen, and you can appreciate the A lines. So these are not true B lines. So whenever we are looking at a vertical line, we have to differentiate between the true B lines and other lines like B line or Z lines. And if these vertical lines are coming up to this middle of the screen, these are Z lines. With the ultrasound, we can identify the other different findings also, like pleural effusion, as we can see. Fluid being a good conductive material for ultrasound, we can easily appreciate, and we can see the underlying collapsed lung here. If you put a M mode, we will see picture like this, that is the lung is coming and going from our side of the probe. So it indicates sinusoidal sign. If there is an underlying lung, trapped lung here, which is not getting ventilated and getting compressed because of the fluid, so we can easily appreciate atelectasis. We may get some small amount of air bronchogram, but this will be mostly static air bronchogram. But there will be challenge if there is a hydropneumothorax. Because of the movement of the air at the air-pleural interface, it may mimic a lung sliding like here. And the bubbles that are placed in the air-fluid tissue interface at the parietal pleura, it may create some vertical reverberation artifact like this. So we need to, by mimicking B lines, that we need to differentiate in case of hydropneumothorax. Now for consolidation, because the air is coming and going, we'll get a dynamic air bronchogram. And because the lung is solidified, we'll get a true image of the lung. We need to remember, to diagnose consolidation, ultrasound is even better than CT scan, because CT scan cannot diagnose dynamic air bronchogram. They mostly say it's a collapse consolidation. They cannot differentiate between collapse and a true consolidation. When the new onset pneumonia is developing, what we'll get certain amount of maybe pneumonic effusion, a part of the lung which is totally solid, it will look like a tissue. After that, there will be starting some amount of aeration. And so we'll get some irregular initiation of B lines from that solid lung. So this is called straight sign. It indicates the pneumonia and evolving pneumonia. But sometimes we can miss a pneumonia with an ultrasound. That part we need to remember. So in 1.5% cases, pneumonia does not have any pleural representation, and that will be missed with an ultrasound evaluation. And sometimes whenever evaluating the left base of the lung, you may accidentally or mistakenly identify the gastric content as a consolidation. You can see this is a true consolidation of the lung when there is a static and dynamic air bronchogram, and you can see some amount of vertical B lines here. But here, if you appreciate, this is the gastric content, this is the stomach. But accidentally, this may appear as a consolidation. So, and make a false diagnosis. With an ultrasound, we also can check for the recruitability of a collapsed lung. Suppose here, with an ultrasound, we can see there is no improvement in the aeration of the collapsed lung during respiration, and probably it may help by improve by draining of the fluid. We can increase the PEEP also to see whether this solid lung will open up to some extent. There will be more aeration, and you can see B lines compared to this solid lung. But we need to remember, whenever we are recruiting a lung with an ultrasound, that ultrasound cannot diagnose hyperinflation. So that part we need to remember in our mind. Now, there are multiple papers which has evaluated the recruitability of lung with an ultrasound, and there are objective scoring system. This is called de-aeration score. When the score 0 is basically a pattern and score 4 is basically multiple confluent B lines. With this, if we follow up the lung in all the 2F zones on a regular manner, we can see whether the pneumonia consolidation is improving or not. After giving PEEP, we can evaluate whether there is a recruitment or not. Because with recruitment, what will happen? The score will shift from 3 to 1 or to 0. That means there will be decrease in the B lines in that area. So objectively, we can decide about our recruitment. Now, what happened in our pulmonary embolism? We need to remember in pulmonary embolism, the pathology is in the perfusion, not in the ventilation. So what will happen? The lung sliding will be there because the underlying lung is getting ventilated. There will be a pattern because there is air in the lung. And if you put a Doppler, you may get a perfusion deficit. But most of the time, you have to interpret this finding clinically. So a patient who is severely hypoxic, requiring blood pressure hemodynamic support, and you find there is a normal lung sliding and a pattern, you have to strongly suspect pulmonary embolism and have to do your clinical echocardiography. And whenever we are doing ultrasound, we need to mention the name of Daniel Lichtenstein, who is called the father of lung ultrasound, who has evaluated different patterns of these ultrasound findings in the lung and try to give us a protocolized approach, which is called Blue protocol. So by this structured approach, we can identify cardiogenic or non-cardiogenic pulmonary edema, pneumonia, pneumothorax, and by adding lower limb venous Doppler, we can identify pulmonary embolism also. This is a must known thing. People, every fellow should know, should read the Blue protocol to have a good understanding of the lung ultrasound. So what happened to our patient? Now the patient was initially clinically better. We decide to wean this off. So patient we put on pressure support of 12 by n centimeter of water, but we found that he is not able to draw tidal volume more than 250 ml. He become tachypneic, respiratory rate gone up to 35%. So now what? What can be the cause of this? Obviously, there can be a non-resolving pneumonia, there can be cardiac problem, those things can be evaluated. But can there be something new that was not evaluated till now? That is the contribution of the diaphragm when we are weaning these patients. Because of critical care myoneuropathy, patient has received a steroid, maybe drugs like antibiotics like colistin or muscle relaxants, or just because of the prolonged sepsis, patient may develop diaphragmatic weakness. And that may be the main cause of weaning failure. Even this can be evaluated by ultrasound. What we can do, we can use the ultrasound scanning at the base of the lung. And what we have to look for the diaphragmatic excursion and diaphragmatic thickening. Here we can see, this is the contractile phase of the diaphragm, this is the relaxing phase. In the relaxing phase, if the difference is less than 20%, it indicates there is a significant diaphragmatic weakness, and that may be the cause of weaning failure. Diaphragmatic ultrasound is coming in a big way to evaluate weaning failure, and probably this patient will need a tracheostomy to wean off and for going for prolonged ventilation. But the challenge is that sometimes there will be non-visualization of the diaphragm. Diaphragm may be obscured by the rib, which is not very uncommon and difficult to get the whole diaphragm. Here in the left side of the picture, you can see the whole diaphragm. But here, because of the rib shadow, somehow we are not able to get the diaphragm properly. And on the left side, because the stomach is coming here, you have to go further back. You have to go more posterior to get the picture of the diaphragm. And to avoid the rib shadow, what we have to do, we have to put the probe in the intercostal space along the curvature of the probe. So probably in the mid-axillary lines, it have to be oblique, in between two ribs, not vertical. Now we are planning to extubate these patients. Now there may be a risk of aspiration also. Can the ultrasound help? It can by looking at the pandial status. We can look at the stomach and see whether stomach is empty or it has some content, in which situation patient may vomit and may aspirate. This is the three position. It is subxiphoid, in the longitudinal, oblique, and in the lateral position. If the stomach is empty, you will get a picture like this. There's the two lumen of the antrum which is collapsed. This is the antrum which we mostly focus. Now, if after giving 500 ml of fluid, the antrum will appear like this. Here we can see there is a content. Because it is fluid and ultrasound can pass easily, it looks hypoechoic. This is a real-time picture. You can clearly see you can appreciate the Rice tube or nasogastric tube in the stomach. And here we can see there is some amount of the fluid is there. It is probably liquid or some very small amount of semi-solid, because if it's a solid fluid or semi-solid food, there will be trapped air, which we cannot see much. Now we extubate this patient. Now the patient develops stridor. Suddenly patient develops stridor. Can ultrasound help? Can we predict this, that this patient has a higher chance of developing stridor? There are a lot of different clinical findings. We can go for a leak test, but size of the tube can be an important point, specifically if you are going for prolonged ventilation. So now, in a certain situation, we can measure with ultrasound, we can measure the subglottic area and can decide that what should be the size of the tube. It is more important in the pediatric patients because the subglottic is the narrowest part, but this can be used in adult patients also, specifically in high risk patients, or if someone who has underlying lung pathology. And after that, if you are not able to win this off from the patient, again, ultrasound can help for a cricothyroidotomy or a or a tracheostomy. We know cricothyroid is an emergency procedure. For that, we have to evaluate the neck with an ultrasound, can identify the membrane. Here, this is the cricoid cartilage, and these are the tracheal ring. So this is the end of the thyroid cartilage. So this will be the cricothyroid. This white margin is the cricothyroid membrane, and we have to go through it. This is a real-time picture. Just for the training purpose, it has been done in the longitudinal manner. And most of the time, cricothyroidotomy or tracheostomy, the needle puncture is done in the transverse view. In longitudinal, it is a little challenging because the angle becomes very steep, or you have to go lateral. You can appreciate the needle movement here. It will be better appreciated here. See, the needle is coming from here. Yes. Now here in tracheostomy, you can see the movement. It is difficult to appreciate the tip. And if you do it in a transverse view, we'll get a picture like this. We'll get an undulation coming from the front, passing the ring or the membrane on the air tissue interface and going into the trachea. So, to conclude, what is the use of lung ultrasound? To rule out endobronchial intubation, to diagnose pulmonary edema and interstitial lung syndrome, that is pneumonia, to identify pleural effusion and atelectasis, pneumonia, pulmonary embolism. Pulmonary embolism a little bit in a clinical context, because if the patient is severely hypoxic with a normal lung finding in ultrasound, you have to strongly suspect pulmonary embolism. It can help in procedures like thoracocentesis, also taking biopsy from the pleural lesion. And the advantage for ultrasound, we all know, it's a rapid bedside diagnostic test, minimal complication related to the transfer of the patient to the CT suite, no radiation exposure, so you can do it repeatedly, low recurring cost. Compared to the conventional belief, there is a very small learning curve, and it is high sensitive and specific for diagnosing most of the clinical finding in our practice. By this, I'd like to conclude my presentation. We're happy to take questions. Thank you.
Thank you, sir, for this.
Yes.
Thank you, sir, for this very nice presentation. It covered a lot of the issues that many people were eager to hear it. So tell me, please, if any tips that you can tell to our beginners of how to put the probe properly and how to get a better view of the lung if they fail to get it from in the first trial.
So regarding the lung ultrasound, technically it is easier compared to echocardiography, because it is much easier to get the images. But what happens that sometimes, specifically in the initial phase, people try to get a positive finding, and whenever they get anything but any vertical lines, they feel this is B lines, and they try to diagnose a pulmonary edema. We need to remember to diagnose something as a true B line, there are multiple characters. To be exact, 7 characters. All 7 characters have to be there. Like it have to start from the pleura or just a pleural consolidation, hyperechoic, moving with base B lines, respiration, have to come to the base of the screen, and it have to obliterate A lines. A lot of times Z lines can be wrongly identified as a B line because it ends in the middle of the screen. Next point is that whenever we are looking at the base, sometimes the rib shadow obliterates. Then in that situation, we cannot put the lung probe ultrasound probe vertically, you have to put it the intercostal space. For that, you have to make it oblique and try to avoid the dip shadow as much as possible. But whenever we are interpreting it, we need to compare the normal side with the pathological side with the normal side also. Sometimes, suppose the patient has a pneumonia and we get a bilateral B lines in both sides, probably it indicates a viral pneumonia. And it's not may not be a bacterial because diffuse involve both sides. So, sorry. So by this, if we do the lung ultrasound judiciously and see all the 12 area, we can identify a lot of findings, and it can help us to diagnose underlying pathology. And last point I like to emphasize, the lung ultrasound is not going to give us a diagnosis. It is going to give us a clinico-pathological finding, clinico-pathological observation. It has to be interpreted into the appropriate clinical context. It cannot just give a straightforward diagnosis.
Very good. Thank you, sir, so much for this excellent presentation.
I have a question, Dr. Amr, please.
Yes, sir.
Yes, sir.
Dr. Sudipta, thank you for your valuable presentation. You said that we have a false negative and false positive outcomes in the case of pneumothorax, right?
Right.
Yeah. So what about the sensitivity and the specificity of ultrasound in detecting other lung pathology compared to X-ray and CT?
For most of the clinically relevant points which we deal in ICU, the sensitivity and specificity of lung ultrasound is more than 90 to 95%, except pneumothorax. In pneumothorax, specificity is around 90%, but the sensitivity is around 70-75%. So that means a small pneumothorax can be missed with an ultrasound if you are not doing it very sincerely and following up the whole lung area. So that can be a little challenging in a busy ICU. But if some pneumothorax is clinically relevant, patient has deteriorated, patient is requiring very high oxygen, may is going to be intubated, then probably those pneumothorax can be picked up.